Are we ready? Well, good morning, good afternoon, everyone. This is a talk on end-of-life presentations, so if you're not near the end of life or know somebody that's in that stage, then you're in the wrong place. But we're all heading to the same place, so this is a good series of talks. My name is Jim Velazny, and I'm with the Ministers of Care Ministry. It's one of the three ministries that are organizing and presenting this series of talks. The other two are the Bereavement Committee and the Respect for Life Committee. So we thank everybody that's helped out here. And I've been asked to lead a prayer, so let's start as we always do in the name of the Father, and of the Son, and of the Holy Spirit. Amen. Dear Lord, we thank you for bringing us together this afternoon. We thank you for being here in our midst. You know, Jesus said, where two or more are gathered together in my name, I'm there. So we have a quorum, and Jesus is here with us in this room. We thank you, dear Lord, for our presenter, Nancy Flowers, who will be introduced shortly, and for her ministry and service at Rainbow Hospice. And we ask you, dear Lord, to open our ears and our hearts to hear her message and to hear your message. Help us to share our own experiences and wisdom as we face the challenges of completing our journey here on earth and coming home to you. We pray for all those gathered here, for their families and friends, and especially for those that need our help and support and that need to feel your loving presence, dear Lord, in their lives. We ask all of this in the name of Jesus Christ our Lord. Amen. Rick, up to you.
Good afternoon. I have the pleasure of introducing Nancy. I've got her her bio here. It's quite long, so I'm going to go through it though. Nancy is the Community Education Program Manager for Mount Prospect-based nonprofit Rainbow Hospice and Palliative Care. If you have not heard of her, I should probably mention that Rainbow Hospice and Palliative is affiliated with what was Resurrection Healthcare, became Presence Healthcare, and now is Ascension Healthcare. Ascension is the largest Catholic healthcare organization in the country, with 150 hospitals across the country. Nancy is a licensed clinical social worker. She received her master's degree in social work from Indiana University, and has 33 years of clinical and management experience working with older adults in hospital, home health care, hospice, assisted living, long-term care, and municipal settings. Nancy is a member of the has been a member of the Leadership Council for the National Consumer Voice for Quality Care, and a board member of the Illinois Citizens for Better Care. Nancy is the former chairperson of the Illinois Department of Aging's Long-Term Care Council, and was a member of the Illinois Department of Aging's Elder Self-Neglect Steering Committee. Nancy is the past president of the Illinois Association of Long-Term Care Ombudsmen, and Nancy was named the 2004 Long-Term Care Ombudsman of the Year by the Illinois Department of Aging. In 2005, Nancy served as one of the governor's delegates to the White House Conference on Aging. She's been a field instructor for local social work programs for over 30 years. So I want to welcome Nancy Flowers, our speaker today. Nancy?
Flipping over. Thank you. Good morning. Can you hear me with this? Okay, great. I tend to get earnest when I talk about this topic, so if my voice gets too low, please let me know. I'm going to talk today about hospice and palliative. And I understand you spent some time, last speaker, talking about advancce directives, so I'm going to weave that into this. But I'm also going to talk about ethical and religious directives that guide decision making. Catholic health care, how that influences, how that influences the work we do with patients, hospices. There's, for those of you that may be about that, and we're going to touch more on this, there's absolutely congruent Catholic directives. Talk more about that as we go on. I'm going to wander back a bit. I wanted to start with this quote from Ira Byock, who is a palliative care physician that has written a number of wonderful books on end-of-life care. But what he says to us is, I've learned that death have to be agonizing. When people are relatively comfortable and know that they are not, they frequently find ways to strengthen bonds with the people they love and create moments of profound meaning in their final passage. This is what we would all hope for. None of us likes the idea of leaving the people we love or having them leave us. But as our opening congregant said, it's what is going to happen to all of us. This is an inevitability. So how do we help prepare people for end of life? How do we help support families in caregiving? How do we help prepare ourselves for decision making around end of life care? That's what we're going to talk about this afternoon. A little bit about us. You have heard we have become part of a very large healthcare system, but we were born in 1981 as a community-based organization that came out of as did every nonprofit hospice at its time, which came out of a community need. We're a longtime affiliate of Presence Health and Lutheran General Hospital, and now a part of Amita Health and Ascension. We serve annually over 1,700 patients and their families, and we're contracted with a large number of hospitals and long-term care facilities and serve 9 counties and counting. So when I'm asked where we are based, my office is in Mount Prospect, but we go everywhere. I'm going to talk a little bit first about what worries us when we think about end of life. And you may have different worries, but often what people talk about is the fear that we will not be able to address their pain and their distress. People may worry about spiritual anguish and suffering without meaning. They question that. Why is this happening to me right now? What have I done to deserve this? They may worry that if I tell you that I have a terminal illness, that you'll pull away from me, that you'll abandon me, that I'll become isolated in my illness. We may worry that we're a burden to our families, physically, financially, that this will be more than they can bear. We may absolutely fear that we will end up hooked up on machines, unable to care for ourselves. That may be a worry for some of you in this room. But often, another worry is just talking about this. I commend this congregation for having a series on this, because often what prevents us from getting the care we want is that we have a hard time talking with each other about the care we want, or asking questions about our health and getting the information we need in order to make good decisions about our care, make the right decisions for us. And when I say good decisions, for each of us, that may be different, depending on my values, on my faith, on the condition itself. It's going to vary. Family, lots of things influence that. But what we're going to talk about, you started talking last week about planning ahead, and we're going to talk more about that, how we have those conversations. Part of why this becomes so important is that many of us may find ourselves in an ICU, in an intensive care unit at end of life. Nearly 2/3 of us are going to be hospitalized in the last 90 days of our lives. And nearly 1/4 of us may end up as this gentleman is here in the intensive care unit in the last 30 days of life. That may be the right thing, depending on the situation, but it may be the last thing you wanted. You may have been thinking, this is what's important to me, but may not have had that conversation with anyone. A third to one half of us may not have, or may have advanced care planning documents that somebody may or may not know that we have. It's actually as high as about 3/4 of us that have them but have never shared them with our physicians or other healthcare practitioners. So how does my doctor know what I want if I don't share it with my doctor? And less than half of us that end up in intensive care are in hospice. What we believe is that at end-of-life care should be about comfort. It should be about supporting the physical and emotional and spiritual needs of patients and families. And you're going to hear me talk about patients and families throughout this, not just the patient, but their loved ones, the people that are caring for them. And it should be about celebrating life. We have people in our world that have gotten married while they're on hospice, that have celebrated their vows. My dad, when he was on hospice, had a pretty significant bucket list that was in his head of things that were important to him. My niece, who had had an interesting high school career, a little chaotic, was graduating from nursing school, a very big celebration in our family. He wanted to be there. He had an anniversary coming up. He wanted to be able to celebrate it. It's a little more low-key than other celebrations. It did involve beer, but that was important. My son was in Sweden having a big adventure for a year. He wanted to be alive when my son got home. He also wanted to eat some of the best hamburgers DeKalb had to offer, complete with good milkshakes. These were part of how he celebrated. I also have arranged for travel hospices for patients that have wanted to go to Vegas one last time, or wanted to go to the Dells with their family one last time. This is what our world is about. It is, of course, with great sadness that we say goodbye to people we love. But how do we help people live well until they die? That is really the focus of the work that we do. So there's about 1.5 million patients that are in hospice right now in about 4,500 hospices across the country. There's about 146 of us operating in Illinois. We do not have what's called certificate of need, so you could start one in your basement if you wanted to. There are a lot of us around, which can sometimes make deciding which one of us is the right one a little confusing, and we're not here to talk about that today. What I'm going to talk about when I talk about hospice is what every single hospice should look like out there. About 46% of all U.S. deaths occur in a hospice program, and I think about how that has grown. From when I first read about the first intentional hospice in the United States back in probably 74, I think I first read it, 75, when Dr. Cecily Saunders came to the United States to talk about what she was doing in England. How that was such a foreign concept, and now almost half of us. About a little over 80% of us will die in some kind of a community setting where we live. That may be a house, maybe a condo, maybe a nursing home, it may be assisted living. We have cared for people in converted garages and in homeless shelters as well. It is wherever you need us to care for you, we come to you. Nationally, about 18% die in an inpatient facility, either in a hospital setting or a specialized hospice setting. And these are people who need a higher level of care. So we'll talk a little bit about that as well, why somebody might be admitted in the hospital and care under hospice, and why others, the vast majority, will be cared for in a setting that they call home. You'll be happy to know that most of the people we take care of are older adults at the end of their life. 84% are 65 years of age or older, and another 47.5 are 85 years of age and older. But there are hospices that care for children, because sadly children do die as well. And so there's actually several hospices in this area that provide care to children who are dying. And the care is a little bit different to the adult hospice benefit. We have chosen, we feel our expertise is adults 18 and over. So that's more a choice because you need very specialized teams working with children. It is different. And then the diagnoses vary. When hospice first started, the vast majority of the patients we cared for were cancer patients. And in many countries, that's the case because the resources can be scarce in some countries. But in this country, it is any condition that limits life. So you will see people with cardiac conditions, respiratory issues, and even dementia, which eventually results in the death of the person. These are all terminal conditions with their own criteria for when someone is eligible for hospice care. And we're going to have time for questions, but if something comes up that you're really eager for me to address, feel free to ask. But I'm going to make sure you have time. We're going to talk a little bit about the differences, briefly, between hospice and palliative care. How familiar are you with those two terms? Nope, it's all right. So some of you not at all. Palliative care is, well, actually all comfort care. Hospice is a type of palliative care, but what we're really talking about when we speak this is the service itself, which is a consult service. It is a very specialized area of medical care. There's specially trained physicians in our hospice, all board certified in hospice and palliative medicine, but they're part of a team and it's an interdisciplinary team, and you're going to hear us talk about the importance of the team in collaborating and providing care. So in the case of palliative care, it's physicians, nurse practitioners, social workers, and chaplains that are helping address those concepts that I talked about earlier, that this is really not just about pain and symptom management, very important, but also emotional and spiritual distress that affect people who are facing life-limiting conditions. And in the case of palliative care, this is a consultative. These are consultants, like your cardiologist, like your pulmonologist, to your primary medical team to help address the symptoms, pain that can arise from a chronic condition or potentially something that may become life-limiting. The difference between this and hospice, a primary one, is that this service can be offered concurrently with curative treatments. So if I have cancer and I'm receiving chemotherapy or radiation, palliative care may be really helpful to me if I'm having symptoms, side effects from those treatments. Or if I'm struggling with some decision making about what to do next. Or I have a condition that results in me coming back and forth to the hospital multiple times. And I maybe haven't really sorted out, do I still want to continue this treatment? Palliative teams can provide education, address symptoms, provide a lot of teaching and support, patients and families, as well as education and consultation to the treatment team working with the patient. So this doesn't require a terminal diagnosis or the 6-month prognosis that you hear about with hospice. This is concurrent with treatment. Yes? You can certainly talk to your physician about that. It's a physician order, as the same thing with hospice. We need a physician order in order to initiate. But When my aunt was in the hospital a few years ago and was in intensive care, a full code, very alert, but a full code, and we were concerned that her kidneys might be failing. We were concerned about what might be happening with her health. And I came up from Illinois to help with some decision making and said, I talked with the intensive care team about, here are her goals of care, here are mine. We want to talk about that. Their offer was, wonderfully, would you like palliative care to help facilitate that? Had they not asked, I would have asked. But some hospitals are very folk-oriented on that. The hospitals we're affiliated with have palliative in most of the hospitals, Barney. It's our head of our palliative program here. In most of the hospitals, and most of the major teaching hospitals around in this area do have palliative teams in them. So you can ask, is this available? Yes.
Can you talk a little bit about palliative with chronic pain and medication management?
There are some hospitals I know that are establishing palliative programs. Is that something that they would probably, I'm going to now pick on Marnie, I'm sorry, but I know some of the hospitals around here have developed palliative programs that consult very actively with patients around their symptoms related to a chronic condition. And that's certainly something we've addressed when people have come onto the hospice side. I don't know if that's... No.
No, I was just wondering if, because people with chronic pain don't have a place to turn, and we've been referring people to palliative care for pain management and to avoid opioid addictions.
So right now, as most of you all know, there is a huge, for lack of a better word, kerfuffle with pain management in the U.S. healthcare system. It's a very big challenge. It's a challenge for patients, it's a challenge for providers. And it is in the midst of the pendulum swinging back and forth that this has happened. Palliative care in general works with people with symptoms when those symptoms have come from a treatment plan or a disease state. So, for example, cancer-related pain, dyspnea, shortness of breath related to heart or lung conditions, energy issues related to the medications that come along with a treatment plan, nutrition questions that come along with treatment plans. So, for example, usually a pain patient let's use the example of a chronic low back pain. Someone had a back injury from a car accident when they were young, and they've needed pain medication for their whole lives. That is generally something that would be treated by a multidisciplinary pain clinic. Palliative care, because of its focus on looking at psychosocial issues, emotional issues, spiritual issues related to end-of-life processes, not necessarily because someone is dying, but because this is limiting their life expectancy, perhaps, that's generally the strain. Now, 1 or 2 palliative care clinics in the Chicagoland area do take chronic pain patients. One is at Rush, for example. We have found in our practice that a multidisciplinary pain clinic, like a group that combines physical therapy, biofeedback, lots of issues like that, when the only major issue is a chronic pain piece, that those multidisciplinary clinics are better suited to that type of symptom. I know it's about as clear as mud, but if the issue itself is pain versus a symptom that has been brought into the mix from a treatment plan, the latter is really more where palliative care would have its strengths.
And those clinics actually have a number of different modalities that they can use to treat pain. I did a number of patients that I worked with when I worked at Rush who were part of the pain clinic there. Very, very effective. So thank you. Sorry to do that, but I wanted to be able to do this. These are consultations that are not just available in the hospital setting. Well, as I said, the hospitals we're affiliated with, we have palliative programs in them. At least a physician and a nurse practitioner, and in several of them also a social worker. And we tap the hospital chaplains in the hospitals that we're in. But we also, there are community palliative programs across this country where people go in and serve people who are in long-term care facilities, who are in assisted living, and see people in their homes. So again, programs that can go to where people live. And Marnie talked very nicely, thank you, about some of the burden of the symptoms that we attempt to address through palliative care. That really the focus is on quality of life, and you're going to hear this a lot, as well as what's important, helping people determine what's important to them at this point, really looking at how do we help you function as well as we can by alleviating symptoms. And those symptoms may be pain, they may be dyspnea, but they may also be anxiety, distress. So looking at how do we help address symptoms that may arise from many different conditions that affect health and may end up becoming a terminal condition. Yes? Support system, can you help me understand a little bit what you're in? Well, and so what you're talking, if you have a family that is in conflict, if you have a decisional patient, they get to make the decisions about their health care. If the person is not decisional and has advanced directives, as you may have discussed last week, the person who is the power of attorney, the patient has designated that person to make decisions for them when they lack capacity. If there is no legally designated power of attorney, we have, I don't know if you talked about the Surrogate Act your last presentation. There is state law that in certain cases, particularly when we're looking at a patient with a terminal condition, medical staff in the hospital, two physicians can identify someone within it could be within the family or a friend, to make decisions on behalf of that person if they have not identified anyone. If there is absolutely no one, and there are treatments that need to be, that the hospital is recommending treatments, then the hospital can petition for guardianship that process be initiated. And it may be, or a family may pursue guardianship. Particularly if there's conflict, you may see people contesting that, or a couple of people pursuing guardianship. Court process, it can be lengthy if there are co-applicants. Emergency guardianship can also be determined, and the county can become the guardian, or the state can become the guardian as well, depending on the situation. But yes, we generally try to help families navigate this. This can be a very emotional time, not surprisingly. Families have strong feelings about care. They may even disagree with the person making that decision. Even the patient themselves think they're giving up, or thinking they're pursuing too aggressively. So emotions can get high. Our role is to try to help facilitate that discussion, so we hopefully don't get to that point unless it's absolutely necessary. Welcome. So we talked about the fact that, yes? Medicare, if someone has Medicare, it covered, private insurance covers it as well. So most insurances do cover palliative. Yeah, well, it's because it's a physician ordered. So So palliative and hospice are both insurance covered. We have cared for people who do not have insurance in our system, and every system has a setup for doing charity care if need be. But out in the world, Medicare is probably the primary payer that you're going to see for most health care in this area, because most of the healthcare users tend to be older adults in this area or people with disabilities who have Medicare, but private insurance does as well. And that's just an important question to ask. Yes? That is absolutely okay. So there's several layers to that I think are really important, and we will continue to talk about this, but I think for us to be able to, when I said this is about how we celebrate life, how we help people live well until they die, part of that is to be part of a care circle, whether it's your faith community, your family, your friends. We all define family in different ways. It may be people we're blood related to, it may be dear friends. But having people who care about us, who care enough to check and see that we weren't out in our gardens, make sure that we're okay, and people who can laugh with us. My dad, while he was in hospice, loved holding court with his friends, and they would tell jokes and they would tell stories. This gave him such great pleasure, and I would argue probably extended his life a bit. We all need that in our life. Think about how, just for those of us that are not facing a terminal condition, how bleak life is when we feel we have nothing to celebrate. It's a really key component to feel cared for and to care for others, and to know that somebody cares about what happens to you and how you feel. I have a friend who is not yet terminally ill, but is in the middle of her dementia, and our goal every week when I have dinner is that we will spend at least half the meal laughing. It's a really good goal, and I hit it every time. We just laugh. The quality of life is tied to that sense of affection and caring and connectedness. And so as we continue to talk about hospice and palliative care, you will hear us talking about this total pain management, that a concept that was crafted by the mother of us all, Dr. Cecily Saunders, who was the founder of the modern hospice movement. We've always cared for the dying, always, but she helped begin to talk about how we could do this differently and better. And it was she who really talked about the fact that, yes, we were focusing on pain and symptom management, because that's what scares us the most. But equally, what scares us is the distress, the fear that we'll be isolated and abandoned, our sense of spiritual challenge and loss. And that all of those, that's why you have a team, whether it's in palliative care and hospice, to help support and guide and address people, because we need to be able to feel joy. We need to feel connected and cared for. Really important. So that's why you're going to continue to hear us talk about team and the importance of addressing all of those components as we work with people. But yes, yes, yes. This is your family. This is one part of your family, and how you care for each other. And one of the things that we do, our chaplains that work so hard, is whether or not they share the faith of the person, they're going to help make sure this person is connected to their faith community as they want to be. So we talked about that palliative is a consultative service, addressing symptoms, helping guide some decision making, helping people who may have been in and out of the hospital a number of times because they're just not, either might be very appropriate or they're just not sure what next. And so that guidance, that education, helping people problem solve, maybe even completing advanced directives, may be something that the palliative team will help with, but helping sort through what next. The little rainbow that I had up on the screen earlier, I like to think about as it shows this progression of when we first start, we're looking at an illness. In the beginning, curative treatments are really primary importance. You're going to see more of these disease-directed therapies. And palliative coming in is more of a consultant service. But as a person's condition changes, we will take a more active role as needed, and may very well be part of the guidance toward hospice if that's appropriate. But that sense of education about options, choices, helping people sort through the effectiveness of treatments and how they feel about those, and what their questions are and their worries are, is part of that team's helping guide people through the decision-making process. The hospice is also comfort-focused and focused on very skilled medical care to address pain and symptom management as well. But hospice comes in when curative treatments are no longer effective, when they've stopped working, not before then. So if someone is receiving treatments and they're working, and the person is really happy with how this is working, and they're in agreement with their physician on treatment, that's what they should be doing. But for many of us, a time will come when those treatments stop working. Chemotherapy is no longer keeping the cancer at bay. Heart function changes. Recently had a friend whose his kidney function, even despite being on dialysis, becoming more and more compromised. So we may find ourselves beginning to wonder and talk with our physicians about the what next. And so what hospice is going to focus on is that total pain management that I talked about, but also helping patients and families begin to ask some of those questions and helping them deal with the complexity and grief of end of life. And working with them to identify, again, the goals of what's important to them at this time, what matters most, what does quality of life mean to you, and what kind of care do you want at this point. So whereas palliative was a consult service, hospice, paid for by insurance, really is very comprehensive insurance benefit. We're paid to manage your care, paid to really help you in identifying how many visits a week we may need to provide to you, what kinds of treatments in terms of pain management, supportive therapies, how often should the social worker be out, how often should the chaplain be out, how often should the home health aide be out to help you with bathing, what do you need to support you in the care setting you're in, to help you have as good a quality of life as possible. We don't replace the family as a caregiver, we support them. So whether that's a family member in the home that's providing care, a hired caregiver, nursing home staff, we supplement, we educate, we partner with care. The only time we become the sole providers, in some ways, is when people are in the hospital or they're in a specialized hospice unit where we become the physical caregivers. Families are still a critical component to that care, but we would take on a more active role in that care. The other difference with this is that this is a service that is available 24 hours a day, 7 days a week. We're not going to be sitting at your house providing this. I know that's a disappointment for many families. But if, as happened with me when I was helping care for someone and I wasn't quite sure if we had given the right amount of medication, to be able to pick up the phone and hear a knowledgeable nurse on the other end of the phone say, "You're doing great," or "You might want to, let me talk to the physician and see if we need to increase this or not." But to hear someone say to you, "This is what I would suggest now. And if that doesn't work, call me back and we will send a nurse out to help you." How comforting is that if you're a family member who is caring for someone you love? Or if you're a nursing home staff member and this may be your first death. So that availability 7 days a week, 24 hours, is a real critical component of what we do. So we have staff on, including physicians on call, nurses on call, social workers on call, chaplains on call, and even not so much on call, but aides who cover 7 days, depending on what you need. So that availability is there. And it is the most comprehensive Medicare benefit that there is. We walk through it, you'll see why. We're all licensed. We're all required to be licensed by the state and federal government. And although Medicare is the primary payer for the vast majority of the work we do because of the age of the patients we have, we also, Medicaid covers hospice, private insurance, and for people who are underfunded or unfunded, there's charity care. We fundraise for that service. The challenge is that, so we're going to talk a little bit about eligibility, that sets 6 months, if your physician look at you and wouldn't be surprised, believes that given your course of your illness progression that you would die within 6 months or less. 54% of the people that enroll in hospice will be on with us for 30 days or less. And 27, almost 28% will be on with us for less than a week. It is not, and this is often becomes a worry, and we're going to talk a little bit about myths, that going on hospice kills people, shortens their life. It's actually quite the opposite, that addressing pain and symptoms can cause you to live longer. But it's because of that hesitance that we have to talk to each other about end of life and what's important. People often are referred so late in the process that they end up on being on hospice for a very short time. And so the benefits that we're going to talk about that people can get are less. We still have families who are grateful even for a few days of care, but it's very different when you have a situation like with my dad, who was on for 7 months and developed a profound relationship with his hospice team, to the point where he wrote them kind of a love letter that I have up on my wall that talks about how grateful he was that they helped him over the bridge, and our families who come on and die within 24 hours because of the delay in referral. But it's a challenge, yes.
How many people are discharged from hospice? What percentage?
It's a very small, there is a percentage, and I'm trying to think, I should know that. That's an excellent question. That first week, sometimes people may change their minds, because part of the hospice benefit is that if I enroll in hospice, I can change my mind. I can decide I want to pursue treatments. I can decide that maybe I've heard about a treatment that I think is going to be the one. People can fire us. So a certain percentage may sign off. But there's also people who graduate from hospice. Symptoms get addressed. People with advanced dementia and other neurologic conditions, Parkinson's disease, ALS, MS, may stabilize. And so It's not that they won't die from those conditions, they're just not actively declining right now. So they will come off, and we have discharged from that, and I can get you that information. I forget what the percentage is, and 5%, Marnie thinks 5%, thank you. But it's very small, very small percentage.
And could you explain the difference between in-home healthcare and in-home hospice?
Okay. So in-home health care, and we often offer that in conjunction, or that can be offered in conjunction with community palliative care. In-home therapy, in-home health care is for people who may not be actively dying, who have a condition that warrants skilled nursing intervention, skilled physical therapy at home. So someone who's maybe has been in rehab for a stroke, who may have had a hip replacement, knee replacement, may have had a heart attack and has had cardiac rehab, and their physician feels like they could benefit from a little more home care. Medicare will cover that. It's time limited, and there's some changing rules that is going to change it further coming up. But it's for people, in order to get home therapy, it has to be very difficult for you to get out of the house. You have to prove that it would be burdensome for you to go to outpatient therapy, that it would be more difficult. So the therapy and the nursing can come to you. Wound care may happen at home. So that's a Medicare service. You cannot have skilled home health care and hospice at the same time because they pull out of the same Medicare benefit. So that may happen first.
But hospice doesn't provide 24-hour.
No.
Right.
So 24-hour, if you're looking for a 24-hour caregiver, if you say are going to live at home and need a caregiver, that's an out-of-pocket expense. There is some subsidy through the Department on Aging and the Department of Rehab for part-time caregiving, but no one pays for 24-hour care unless very, very unusual circumstances. So that's a private pay expense. And we do have people who have 24-hour caregivers in our care that they're paying for, and we are working with that caregiver and the family.
And then do you have volunteers on your teams?
So all nonprofit hospices, in the beginning, when Rainbow first started, we were a volunteer hospice. And that's how every hospice started in the 80s. Our origin story is that a woman wanted to care for her husband at home. They had small children, and her church community, so back to your church community, helped her take care of him. And she was so moved by the experience, she wrote the 501c3 paperwork that created us. That is the origin story pretty much of every single hospice that started back there. The hospice that is now Journey Care started that way. The hospice that used to be Midwest started that way. Horizon, the VNA hospices all started that way. And in the mid-80s, Medicare started looking at this as an option to decrease healthcare costs, but also to care for people where they wanted to be cared for, which was in their homes or in the home setting. And so then Medicare and Medicaid started paying for that. But because of that, a certain about 5% of the care that we provide, or the work that we do out of our hospice, has to be provided by volunteers. And that's a unique part. No other area of healthcare has that requirement. So our volunteers do everything from stuffing envelopes and helping us do mailings to being trained to sit at the bedside of the dying. So depending on your skills and your interest, that might be something you would choose to do. You may visit a hospice patient, you may choose to sit at the bedside. So yes, volunteers are an important component, and we have several hundred volunteers that we work with in our organization. And the larger hospices, you're going to hear those kinds of numbers. But when I was in China recently, they follow the same models and use volunteers as well to help support hospice patients that they care for. Did that answer your question? Yes. 17, yes. So there are different levels of care. So we will just scooch right up to that because I want to show you that slide. We're going to go back then because I want to talk a little bit about there are 4 levels of care. Again, when I said about 90% of the care we do is in a community-based setting. So only very small, 10%, or maybe I think a little shifting going on, but around 10% or so is provided in a hospital or an inpatient setting. So most of the care we do is out in the world, out in the community. So that means a team of a nurse case manager, social worker, a chaplain, a home health aide, and volunteers are going out to the home to care for and see patients, to teach families and paid caregivers and friends how to provide that care. We also have music and massage therapists that are part of our world. Those are not required services, but many of the larger hospices have those services as well, because we find them to be incredibly effective in addressing another way of addressing pain, symptoms of anxiety, respiratory distress. So those teams go to where the patient is. They develop a care plan with the patient and family about how often do I need to come out. So maybe you might only want me once a week because you're doing pretty well right now. Or you may have so many symptoms that I need to be out with you multiple times a day. That 24-hourness that I talked about, I was looking at what we call our triage report this morning, and we had staff out all night long addressing issues that were coming up because those kinds of things can't be scheduled necessarily. So if you are running into trouble in the middle of the night, we're going to be going out to you. That's called a routine level of care, and the vast majority in every single hospice in this country, that's the majority of what they do. Most of it occurs during daylight hours. You'll be glad to know. But there's also, we can also provide it when emergencies come up. When we are in a setting like Journey Care has, they have several inpatient levels of care, and there's 2 different kinds. There is what's called general inpatient level of care, and then there's about 9 hospice houses in the state that these are settings where people can go and live and be cared for and pay. They're private pay. So we actually have one in our META system. There's a set number of beds that each of them can have. It was just recently up to 20, but most hospices that were built earlier that have 16, which is what the capacity was. So in an inpatient setting, we have an inpatient unit that is of a hospital kind of criteria, but prettier, is set at Resurrection Medical Center. So 16, we have actually 14 beds, because you can have up to 16. We have 14 beds, and the staffing is a physician that's there every day, and round-the-clock nursing. Social work is there 5 days, but we can have people come in on the weekends, and the same thing with chaplain. We have 5-day coverage with chaplain, but we can have people come at other hours. So those are for the folks that are in patients who need inpatient level of care. These are people who are far more symptomatic. It might be difficult to manage their care at home because they need more medical intervention. They need the services of that physician taking a look at them. They may need medications being given more often or in a different route than they would be at home. Yes? So if you are there for symptom management, basically when your symptoms are they're being managed, and I'm stable, and I'm responding well to medications, At that point, we would be talking about moving to either returning to where the person had lived or finding them a new place to go. If it's a hospice house, and again, there's only 9 of them in the state, one at Alexian Brothers campus, Journey Care has 1. Those patients can stay there until they die. We may have someone who comes into our inpatient unit for symptom management, and they may stay because they then they're actively dying. We're not going to move them if they are actively dying. People may be admitted directly in a hospital setting because they are symptomatic in the hospital. They are admitted to hospice and they have symptoms that need to be addressed right now, or they're actively dying, too fragile to move. We would also admit them in the hospital. So we actually use our hospital system. We have 1 inpatient unit that's part of Rainbow. We use the hospitals in our system to provide inpatient level of care as well. So they're different. They're thinking about it as a hospital level care can be helpful. The difference is that the hospice team is directing that care and making sure that this person is comfortable and symptoms are being addressed and the whole team is coming. Yes. If it's a hospice house, it is private pay. If it is an inpatient unit that is a hospital level of care, the general inpatient level of care, that is covered under insurance. It's a different level of reimbursement under Medicare. You don't have to worry about that part other than it is covered. So that's why your question, how long can you stay, it is very much it's symptom driven. And it's how the person is responding to that treatment. So it's thinking about it as you would with a hospital setting. You can't stay indefinitely in the hospital. The same thing with the inpatient level of care. But part of our job is every day we should be looking at the people we're taking care of and assessing, do they still meet criteria? Whether it is they're in a general inpatient level of care, or they're at home. Do they still need us? Are they declining? Do they still meet criteria? So we are doing that assessment every day and talking about discharge planning if somebody needs to move to another level of care and then helping them do that. Yes? No, it's not. Let me see. I had them down at one point. I can actually send that. They're on the Department of Public Health website. There are a few downstate. Most are located up in this area. There's one out in Boone County. There's several in Cook, but they limit. The Department of Public Health limits how many there can be and the number of beds. Yes. Oh, that's a beautiful question. So part of what, go back here a minute. So part of what I want to talk about is how we find out, sort of how we help people clarify what they want. So part of your conversation that you had with your last session talking about the benefits of advanced care planning is that it's really important for us to think about ahead of time what's important to us, what does quality of life mean to us, what kind of care, as we think ahead, what kind of care do we want when curative treatments are possible, and what do we want end-of-life care to look like? And I know that's really hard. Most of us, it's not unusual for people to say, well, I want everything done, not really knowing necessarily what that means or what the answer should be. And so that's where being able to have frank conversations with your physician, with a palliative team, can be so helpful. So what I like to do with people when I'm in a situation is I like to ask them how they understand what's wrong with them, how they understand their condition. I'd like to find out what their worries are. I'd like to find out what they had hoped was going to be happening right now and how they understand their conversations with their doctor, particularly when it's something related to something as emotional as nutrition and hydration. Has there ever been a conversation about feeding tube, if that's being recommended? And what's the condition that's being used to address? Is that feeding tube going to help this person live well and have a good quality of life? Then there might be a reason to do that. If this person has advanced dementia and is in active decline, and that feeding tube is not going to stop that. If you look at the Alzheimer's Association website, they would recommend against putting that feeding. If you talk to many geriatrician and palliative folks, we would talk about what that very question is this going to enhance the person's quality of life, will it actually stop the dying? And in many cases, it will not stop the progression of the condition. We're going to talk in a moment about what the ethical and religious directives say. They actually support that decision making, looking at the benefits and burdens of care is an important part of how we make decisions about care, and the church is supportive of that decision making. But if I were faced with that, and we all will be at some point, I was when my mom was in hospice. I knew what she wanted. She and I had conversations, and that's the benefit of having advanced planning conversations. She also had a condition that I knew from which she would not wake up and was not curable. And so feeding tubes actually never came up because she was so close to end of life. But had they, I know what my answer would have been, that this would not have stopped her dying, would not have been her wish. It would have been burdensome on her body, which was starting to shut down. But I know I do this work. What's important if I'm sitting in a hospital and I'm being asked, what do you think we should do here? There are questions I would be asking to the care team. I would want to know, is this going to be helpful? Is this going to stop the dying? Will this help? Let's talk about how this is going to help her function. And what would her preferences be? I try to help get the voice of the person in the room too. What would they want? Yes? Mm-hmm. Yes. First of all, by not steering, I think the important question is, again, to start with what this person is hearing, what they've been told, and what's their understanding of what they've been told. I also like to ask what questions they have. What do they want to know from their physician or from their oncologist or whoever is the treating person? And I've actually sat, when I worked in an acute medical setting for many, many years, and we would sit and write the questions down. And in a time when we worried a little bit less about this, the patient would sometimes tape the questions onto their bedside table for when their doctor came in the room so that they had them there and could say, okay, here's what I want to know from you. Is this going to help me? Is this going to, what's the chance that this is going to help me get better? So those were actually my dad's questions about chemotherapy with his cancer, which it turned out to be, he had a rare blood disorder then in about 5% of people, it's to leukemia. he won that one. And so he had leukemia that his physician had initially felt would not be treatable. And my mom kept asking, isn't there something? Isn't there something? Can't we try? And that was my dad's question. He actually did start on chemo, had one, actually oral chemo, and it started affecting his vision. And my dad was already legally blind, so his excitement about going blind and dying was, you imagine, it was kind of what did it for him. But his question to his doctor was, if I was your dad, would you do this? And maybe that's not a fair question, but that was my dad. And he also asked him, what's the likelihood that this medication is going to get rid of my cancer? And the physician said, it won't. So having that information was really helpful to my dad to make a decision. And for each of us, that becomes, it may be that what the palliative team will do is to help the person frame the questions they have and to figure out who needs to be there. Yes, Marnie? Absolutely, because this is your world. You want to come?
Thank you. Hello, everyone. I don't think I know very many of you, but I'm a parishioner here at OLPH. My name is Dr. Marnie Fetzer. I'm board certified in hospice and palliative medicine as well as emergency medicine. And I have had the good fortune to work with Nancy Flowers for many years, who is amazing. And thank you for all this information, Nancy. I just don't want to go too far without thanking you. This is tremendous information you're receiving here, and I'm very grateful for you spending time with our parish. One thing I want to offer is none of us are perfect. Physicians aren't perfect. We are trained in a way that goes very narrowly and very deeply. So what I mean by that is this. If you work with an oncologist, they are going to spend the majority of their time learning the craft of oncology. And they're going to learn it very, very well. And they're going to do their darndest to guide you as effectively as possible. But just like oncology, the field of hospice and palliative medicine is changing very rapidly. And not only is the medicine changing, the governmental regulations are changing. The recommendations coming from various subspecialty organizations are changing. So that's where we spend our time. So I try not to be too hard on my colleagues who don't do what I do, just as I don't do what they do. So they may not have a great way or a great understanding of what hospice and palliative is or what it can do or what all the recommendations, for example, around feeding tubes are in various conditions. But there are people who might. So in light of those questions as far as, what's next, there may not be an oncologic approach, but there is always something to do to focus on quality of life. Always, 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 always. It doesn't matter if you're an advanced heart patient, advanced lung patient, an advanced cancer patient, or any other version of the spectrum. There is always a place to focus to improve quality of life for the time that we have left. So no matter who you're interacting with, please just know that. The medical system, although we may not be gifted with words, in no way wants to abandon anyone. We want to be there and walk with you through every step of your lives. And there are tools to do that, whether they are as upfront or as comfortable with explaining those tools and how to access those tools. They may or may not be, but you can always ask, who can I talk to about how do I get support for the next stage of my life or the next stage of care for the people I love? There's always people around. Agencies like Rainbow or Journey or any of the other organizations, they're there to support you. People who do this work are doing it because we've been touched by it ourselves in most cases, and we want to be there to help walk with you. So even if someone may phrase it with not much delicacy, the truth is there is always very sophisticated medical care and very sophisticated levels of support, or maybe even just simple common sense ones that can be by your side to continue to support you, even if there isn't an oncology treatment or a heart failure treatment that's going to restore you any further.
We often will talk about this because sometimes we'll be the one walking into the room after a physician has had to deliver bad news, that a treatment is no longer effective. And what people will hear is there is no hope here. And I was struck by, when I came in today, talk about 3 degrees of mercy, and there was some language in here about hope. What I want to build on what Marnie is saying is that this is a different kind of hope, a hope for a good death, a hope for comfort, a hope for someone to hold your hand and guide you through and provide education. That's perhaps, I think, the biggest part of the role we can have, is that education around what is this going to look like? What am I going to experience? What is the dying going to look like? How do I take care of my relative? How do I manage symptoms? What am I going to feel like? Am I going to get through the grief? Am I going to survive this? Is somebody going to hold my hand through? So I want to, so part of what the Medicare benefit pays for and all of that is all of that education, that assistance with care, cost of medications related to symptom management, the durable medical equipment that's going to help this person be comfortable wherever they're living, and supplies, but perhaps also most importantly that during the period of the dying and afterwards, anticipatory grief and supportive grief work that continues for 13 months after the person dies. So that sense of that hand holding that continues through the dying and afterwards is really critical. We're getting close to time, and I wanted to make sure that I talked about the ethical and religious directives, because I understand there were some questions that came up the last session, and I want to be able to speak to these. This is something I teach all of our staff that start at Rainbow. Before they see a patient on their own, amongst other things, we teach them about the ethical and religious directives, which has some congruence with every single major faith that touches our patients. So, but this is in reference to the directives that were developed by the United States Conference of Catholic Bishops, and they were revised in 2017 because we were all busy merging health systems, so they wanted some good language around that. So when, just for you to know, when any 2 systems merge in this country, if they are Catholic, they're faith-based Catholic, it goes to Rome. We have to be able to show that we have consistent missions and approaches to health care, and that we ascribe to the directives. These are the moral principles that guide us in the care of our patients, and they guide us in the care of every single person we did. So the key things that I just wanted to touch on, because every question here is sort of connected with that a bit. And I'm going to be post-sharing my presentation with you all, so if I missed something, we didn't get to something because of your excellent questions, you'll have what I might have talked with you about. It also has my contact information if you need more. So the guidance on end-of-life care includes that we are obligated to provide opportunities to prepare for the patient to prepare for their dying. That means having that conversation with people, making sure that we are giving them the information that they need to make informed decisions about care. There's language in there that talks about that we should be engaging patients and families or legal decision makers in decision making about care, and we need to make sure they understand their care, their condition, so they can make decisions. Our obligation as healthcare professionals is to make sure that we're talking with people and giving them the information so they can evaluate the benefits and burdens of care. That discussion about of the feeding tube, is this going to make this person's life better, or will it be more burdensome? In order to make that decision, I need to have information from my doctor and from the healthcare team that helps me make that decision. But we also need to be able to provide spiritual support and the opportunity to receive sacraments. So that's an area we're helping people making decisions. This is a clear directive to us. There's language in the directives that also talks about two very interesting areas. If a treatment's going to help me get better, not going to be too burdensome and I stand a good chance of getting better, then that treatment should be offered. But if it will not, if I have the right, or my legal decision maker has the right to forego extraordinary means of preserving life that don't offer reasonable hope. This is direct language from the directives. So people can make the decision to say, let's stop, as well as offering something that's going to help a person. In terms of nutrition and hydration, this is, I think, a really helpful language for those of us that struggle with this. This is, in my experience, the most difficult area to navigate, particularly with people with advanced dementia, because 100% of them are going to have difficulty with swallowing, and every single dying person at some point will lapse into consciousness. They will not be able to eat. And so we struggle with what we should be doing. And so what the directive says is that we have an obligation to provide nutrition and hydration to people who can tolerate it. So if a person has a feeding tube, even if they're in a chronic condition, in a chronic state, in irreversible conditions, but they can tolerate the feeding, we feed them. But it becomes morally optional, and this is the language from the directives, not my language. If that cannot be expected to prolong life, the person is actively dying, the body is shutting down, this is not going to stop the dying, we can have discussions about either not feeding or withdrawing feeding. It would be excessively burdensome for the person, so as we're dying and our organs start to shut down, our kidneys shut down, and I can no longer process fluids coming into my body. If you keep putting fluids into my body, those fluids look for some place to go, in a nice cavity here. And I then develop fluid overload. I have difficulty breathing. I become uncomfortable. It becomes more distressing for me to have fluids coming in than if you were to either lessen it or withdraw it. And this is, again, this is a very hard decision for everyone, but this is a conversation that as the body starts to shut down, a healthcare practitioner would have with you, and certainly the hospice team would. So we're talking if it's burdensome, if it's uncomfortable, if it would result in more complications. That's when we can make different decisions. If I'm not awake, I can't safely eat anymore. You can make different decisions about feeding me than if I'm awake and asking to eat. Very different. So that's language that may help. It's still hard, but can help us as we sort through decision making. Related to end-of-life preferences, we have an obligation to respect and honor choices people make unless those choices are contrary to Catholic teaching. And so this specifically relates to euthanasia or assisted suicide, which I know you're going to have a conversation about in a couple of weeks. So our patients can say, I don't want this treatment anymore, and we can honor that. But when they ask us, and sometimes people do, can't you do something to hasten things? What we do is we recognize that that comes from a scared place, an anxious place, maybe even from pain, and we address those symptoms and provide support. But we will not give medication that will hasten their dying. There's also beautiful language in the directives about pain and symptom management, and that patients should be kept as free of pain as possible and should be able to die comfortably and with dignity. And you're going to hear the words a lot, the lovely language in the directives about dignity. That people should be able to die where they want as much as possible. My aunt's vote is in her bed, in her sleep. I'm hoping we can do there, but we may not be able to. So that may be modified as time goes on. And again, we have an obligation to help people prepare for pain, for death while they're conscious, but to take the amount of medication needed to manage pain. And sometimes families struggle with this. We've had families have said, can't you give them less so that they're awake when the grandkids come? And you understand that request, but if I'm arching in pain off the bed, we're going to have a conversation around how to help, how to give the least amount of medication needed to manage my pain while keeping me as alert as possible. And that's something every family, I think, struggles with. Yes? Mm-hmm. Mm-hmm. Yes. Yes. And I'm so sorry that was your experience. And I think you're right. It's looking at what is needed here. So when our staff are looking at this, we are looking at the restlessness because there's a certain amount of, there can be terminal agitation that comes at end of life. And sometimes it's very mild. My dad had twitching in his feet that didn't seem too distressing, but we've had people who are much more agitated and restless, and being able to medicate for that or trying different interventions to help that is something we address. It's looking at, because the person loses the ability to tell us verbally that they are uncomfortable, but so we have to be able to read them physically. And I'm sorry you were not. That is, I share that it can be very, very difficult to watch that, and so having the team be able to help address that becomes so critical. Mm-hmm. Understandably so, having a consistent staff members. For some of us, death at home may not be the place, and so that's the other thing. Sometimes people start at that because we all want to, for many of us, we want to be able to do that, and sometimes shifting to a more secure setting where there's more staff may also be a better choice, but it's a complicated thing, and I'm sorry yours. Okay. So she was happy. So she was okay with that, yeah. But I appreciate yours, because every single person, particularly if it's your first death, you're asking, am I doing enough? Shouldn't somebody be doing something? It can feel uncomfortable. Yes. Yes. Beautiful thing. So the congruence, because I know we are at time, and I'm happy to take questions from anyone who wants more, but is that the congruence between the directives and hospice is that we're talking about providing health care to those that need it. The ethical and religious directives from the Catholic bishops. You sure can, and I will show you the link to that. You can Google those and they come right up. There's actually 6 chapters. The 5th chapter is on end-of-life care, but all of them are on our obligation to treating people. They are our guidelines for taking care of all of you. But the key things you'll see reference to dignity, compassionate care, spiritual support, the importance of helping people develop advanced directives and honoring their preferences and helping them prepare for dying, and helping them weigh the benefits and burdens of care, and honoring their request to forego treatment and manage their pain so that they can die with dignity. So that, I raise that because I know that that's an issue that comes up. Some of these are concerns that come up. This is what the Catholic Church says is the care we must provide and the guidelines we must follow. And that is very consistent with hospice philosophy, even if they may not be directly training on this. Yes.
Nancy, thank you so much. I know you're getting close to the end here, but if people have to leave, I do have a paper over there, sign-up sheet. If you put your email address on there, I will be happy to send you the link to everything Nancy's talking about right now.
And including, you'll see on the resource guide, is the first one is the ethical and religious directives for Catholic health care services.
Right,
Thank
this
you for
will be
inviting me
taped.
here today.
Thank you, Nancy.
welcome.
Appreciate you being here. And feel free to ask Nancy questions, but I know people need to be moving on, and it's 3 o'clock. So anyone want to ask a question, they can.
You had very good questions, so.
Nancy, thank you so much for being here. I just want to mention 2 quick things. There was a question earlier about humor. There was actually a study done at the Mayo Clinic up in Minnesota where they had 2 groups of patients who were at the Mayo, and one were allowed to watch anything they wanted to on television. The other group could only watch I Love Lucy and the Marx Brothers. And which group do you think actually did better and got healthier faster? So it was the group that was watching I Love Lucy. So
There is, and yeah, there's a lot of research on the importance of laughter and pet therapy and all sorts of.
And the other thing I wanted to mention is at St. Benedict, the oldest priest in the Archdiocese of Chicago, Monsignor Charlie Meyer, is there. Charlie is on hospice. He went on hospice about 3 months ago. Charlie was having difficulty swallowing. He couldn't swallow. He became bedbound. Archbishop Listecki from Milwaukee was his power of attorney, and they made the decision that Charlie should go on hospice. Charlie, since going on hospice, now the restrictions about what he could eat and what he could enjoy. 2 weeks ago, Charlie had 7 bowls of ice cream in the afternoon. And Charlie, well, probably because of this, is going to probably end up graduating from hospice.
So this is yet one of the things we talk about, and I didn't get to that piece at all, is that when you are on hospice, the rules change in terms of therapeutic diet. So you get to, we modify the diet based on your swallowing abilities. And yes, we can have somebody who eats ice cream all the time. I would live forever. Thank you all.
That's right. The humor, I wanted to mention.
You can go back.
Can you go back?
Yes,
On
yes.
Medicare.
We have people that sometimes come in and out a couple of times before they die with us.
Thank you.
You're welcome.
My mom was on hospice for about a week. It was her wish that she died. Yeah.